Good afternoon. This is an exciting day for our respective groups, so it's exciting to see everyone in the audience today. I thought I'd present a case that encompasses our title of our symposium today, so genetics, immunodeficiencies, and rare. So I'll tell you the story about an 11-year-old female who was clinically well with the exception of mild asthma until about 8 years of age, when she woke one day with abrupt facial edema encompassing the side of her face and an associated red rash. The rash was not significantly altered by sun exposure. On several evaluations for this facial edema, she was noted to have elevated eosinophil counts and also an immune deficiency. 6 months later, she presented to our local emergency room with significant abdominal pain, where appendicitis was ruled out. She also had significant vomiting associated with this continual abdominal pain. As time went on, she also noted symptoms of dizziness and leg tingling. EM did not have any developmental or intellectual concerns. Her height and weight tracked well for her at the 20th percentile for her age. Interestingly, she did present with 6 fractures over this period of time, all in the small bones of her extremities, both associated with and without trauma. She had an allergy to augmentin and had a first reaction to a flu vaccine with the development of hives. She was the product of a twin gestation, which was delivered without complications at 36 weeks. Before she saw us in our genetics clinic, she was evaluated by a number of physicians at a number of well-respected institutions locally in this area. An ENT had ordered a CT of the neck to rule out parotid gland swelling involvement, and that was normal. A bone marrow biopsy did identify hypocellular marrow with mildly increased eosinophils. A GI physician had ordered a barium swallow, and an endoscopy and a colonoscopy to evaluate her abdominal pain, and all of these were normal. She had a chest and abdominal CT, which was unremarkable, and an echocardiogram and an EKG, which were normal. A brain and cervical MRI did identify a Chiari-1 malformation, but there was no obstruction of the cerebral spinal fluid, and a DEXA scan was reportedly normal. So our immune colleagues who had been evaluating this patient sent her to us for an evaluation. And upon our evaluation, we did take her detailed chronological medical history, as well as a detailed physical exam, as Dr. Wilson would be so proud. I took a 3-generation family history, and we ordered initial studies, including the fasting metabolic studies listed there. On family history, we noted that her mother and her maternal grandmother had irritable bowel syndrome. Her father and her paternal grandfather had kidney stones. Her older brother had a history of bone breaks, and her fraternal twin sister had mild asthma. There were no known other genetic syndromes in the family, and consanguinity was denied. Upon wanting more information about this patient for abdominal pain, we did want to learn more about the association with the abdominal pain and the patient's diet history, so we asked the family to complete a diet diary. She also returned for a repeat combination DEXA, as the DEXA that was originally ordered for her was appropriate for a postmenopausal female. And this did come back with an abnormality at the low extreme end of normal with a z-score of negative 1.9. We ordered an EMG and nerve conduction velocities to rule out a neuropathy for her leg tingling, and that was normal. And we did pulmonary function tests in our office, which had the results with a difference in upright and supine values. A tilt table was normal, and we decided to embark on whole exome sequencing while we were waiting for the metabolic studies to come back. What is whole exome sequencing, you may ask? I'm going to give a brief slide description of it, but Dr. Richard will also be describing that later on this evening. Whole exome sequencing is a new technology we're using in the clinic, which targets the protein coding regions of the human genome. It uses massively parallel sequencing to look at this 2% of the human genome, and it will compare an individual's DNA sequence to published reference sequences, the family member sequences. In this case, we used a trio sample with the patient's parents, and control samples with the overall goal to identify causal variants for the patient's phenotype. You'll see here the results for her urine amino acids. What was suggested was a dibasic amino acid urea. You can see the dibasic amino acids listed below, which are cysteine, ornithine, lysine, and arginine. And the differential that was proposed to us from the metabolic laboratory was lysine-uric protein intolerance, or LPI, versus cystinuria. However, the pattern that we saw was not classical for either of these two presentations. In LPI, those elevations would be much more significantly elevated, and in cystinuria, we saw another abnormality on her ammonia that was not classical for that for cystinuria. These two types of disorders are inherited defects of amino acid transport at the cellular membrane level. We did identify mild elevations in this patient's ammonia. As you can see, this is a graphical representation of a protein challenge that we offered for the patient. We decided to embark on this with the information that we received from the diet diary, which indicated that her abdominal pain and vomiting did in fact increase about 2 to 3 hours after ingesting a large protein meal. So we wanted to learn further about this response, and we brought her into our office for a fasting study for her plasma ammonia and her urine uric acid. You can see the columns in blue, which represent the baseline studies, and you can see the clear elevation, or the mild elevation in the ammonia and the uric acid. We recommended that the patient start on a low protein diet at about 1.2 milligrams per kilogram of protein a day, and also recommended citrulline, which is an intermediate in the urea cycle pathway. 4 months later, she did come back to our clinic to repeat this challenge, and you can see nice decreases in red with her ammonia normalizing and her urine uric acid also normalizing. So this led us to think that we are dealing more with a condition which is the lysine-uric protein intolerance. This is indeed a very rare condition occurring in about 1 in 60,000 individuals with founding mutations in the Finnish and Japanese population. In LPI, it's a mutated protein which disrupts the exchange of extracellular dibasic amino acids with interstitial neutral amino acids and sodium. And it's the inability to digest and use certain amino acids, namely the arginine and the ornithine, which are the intermediates in their urea cycle, which leads to the postprandial vomiting and nausea. It's also thought that there's an insufficient supply of lysine, which can play a role in patients having short stature, muscle weakness, impaired immune functions, and progressively brittle bones that are prone to fracture. Cystinuria, on the other hand, is a more common dibasic amino acid urea occurring in about 1 in 10,000 individuals. And in this condition, the protein normally allows the amino acids to be reabsorbed into the blood from filtered fluid that becomes the urine. And however, in the mutated version, patients with this condition have a mutated protein that prevents the proper reabsorption of the dibasic amino acids. And it's increased concentrations of the cysteine in the urine, which leads to their clinical presentation of kidney stones. So this is a figure just to represent the epithelial cell and the defects of the transport of the amino acids across the cell membrane. The cystinuria is on the lumen and apical membrane side, whereas the LPI is on the basolateral and interstitial space. So while we were doing this 4 months of protein challenge, we were eagerly waiting the results of the whole exome sequencing, which can take about 6 months to return, and we are interested to see if we would actually indeed find mutations associated with the lysine-uric protein intolerance condition. However, this is what we found. This is a busy slide. I'd like to try to work you through it. You'll see on the left-hand column that there are 4 genes that the laboratory identified as possibly or definitely associated with the patient's clinical phenotype. And on the top line, you see that cystinuria was identified with homozygous mutations identified. I'd like to also draw your attention to the fact that all these conditions are autosomal recessively inherited, which means that a patient must have 2 copies in order to show the disease state. She is homozygous for 3 out of the 4 genes identified, with the heterozygous state being in the enterokinase deficiency gene. It's important to also review the calls that were made by the laboratory. You can see in the right-hand side of the screen the different calls that a laboratory would make based on the mutation information that they found. There were deleterious calls for the cystinuria gene and the enterokinase gene, meaning that the laboratory had sufficient information based on this protein function and information that's been previously published that they could say for sure that this was in fact a disease-causing gene change. However, for the last two genes, the PLOD2 gene and the ScN4 gene, they found what's called a variant of uncertain significance. And this generally suggests that the laboratory was unable to make an official call to say that this gene change was definitely associated with the condition or a benign polymorphism that we might see in the general population. So what do these other genes do, and what are their symptoms? And the enterokinase deficiency is expressed in the small intestine, and in the autosomal recessive form, babies show failure to thrive, edema, and diarrhea, and low serum protein. Now remember that our patient was only a heterozygote in this form, so we're not sure if she had another mutation that they didn't find. However, homozygotes respond to pancreatic enzymes, so there's possible therapeutic value in identifying this gene change for our patient. The PLOD2 gene, interestingly, is involved in the making of collagen, which many of us in this room understand that collagen is necessary for bone development. So patients who have deleterious mutations in this gene have an autosomal recessive condition that presents as bone fragility that's very similar to another presentation of osteogenesis imperfecta, or brittle bone disease. Our patient did have the VUSes in this gene, so it's unclear if there was a direct link with her mutations. The final gene that was identified is the ScN4 gene, which is a channelopathy, and it's involved in transporting ions across channels in muscles and neurons. And previously described mutations in this gene have been known to cause phenotypes of muscle weakness, presenting as both hyper and hypokalemic paralysis and other myotonias. Again, this patient that EM had VUSes in this gene as well. So what do we think our patient has? Well, she's presenting with a clinical presentation that's suggestive of an alternative amino acid transport single gene disorder. But what we really think is happening is that these multiple gene variants are working synergistically together to cause a phenocopy for the lysonuric protein intolerance. So what's next for our patient? We'll continue to limit her protein intake, as well as continue with her dietary supplementation of the citrulline, and possibly increase her hydration for the risk of kidney stones. Her GI symptoms and tingling are tending to resolve. She has been able to return to school in the 6th grade as previously before she was homeschooled with her significant abdominal pain. We'll continue to monitor her for possible development of kidney stones, and we may consider pancreatic enzyme therapy as another agent of treatment. We're still not quite sure how the lung involvement is involved, so we need to consider further if she needs additional pulmonology studies. And we might consider doing genetic testing for the family members, but only if there's only if there's treatment utility for those individuals. So in conclusion, we felt that this case highlights the importance of taking a comprehensive intake for a complex medical history, even in a pediatric patient. It shows that a diligent workup is often needed, perhaps repeating studies to further understand the results and for their specific interpretation, and that it's important to collaborate between the clinicians and the laboratory experts to ultimately come up with a diagnosis that could be life-changing for a patient and their family. So I'd like to thank our patient for allowing us to present her story today. Thank you for your time.